Thank you, sir, for such a wonderful talk. Now I would like to invite Dr. Pallavi ma'am and Dr. Ashutosh sir to facilitate Dr. Krishan Jaiswal, CMO 95th batch, for his elaborative administrative work and achievement in medical field. Welcome, sir. Thank you, sir. Now I would like to request the chairperson to call the next speaker for the topic.
Our next speaker, Dr. Mary Dcruz, I would like to invite, ma'am. The topic is today calorie, carb, circadian rhythm in weight loss. What works and challenge of maintaining weight loss? So, ma'am is MBBS, MD, Medicine, FICP, postgraduate diploma in public health and medical law, postgraduate diploma in clinical endocrinology and diabetes, physician and diabetologists. So over to you, ma'am. Please welcome.
Thank you so much for the kind introduction, and I'm unable to change the slides. I'm sorry. I can't change the slides. So I'd just like to thank Dr. Ashutosh and Dr. Mrs. Ashutosh for their kind invitation. And it has been a wonderful experience since morning I've been sitting. And I'm so glad to be here in Varanasi, the holiest of cities, and also the holiest of days for us, being Good Friday today. It's not changing. So today I'm going to be talking on carbs, calories, and circadian rhythms and what works best. So having a look at that, we will Dr. Sushma has made my talk very easy because she ran through a lot of data that I was going to talk on, so I'll skip through the slides. Okay. So since I had read, this is my first visit to Varanasi and I'm really happy to be here. There's no conflict of interest here in this talk. I'm going to talk on calories, carbs, and most importantly, the challenges of maintaining the weight loss. And unfortunately, there were two topics which had to be combined, so it's a little elaborate, but just doesn't change. So this is going to be the flow of the talk. I'm going to look at obesity in India and particularly women, though it applies to men also. And we're going to look at the definitions, what already has been said by Dr. Sushma. So the only thing that was not addressed was the ABCD definition, which is adiposity-based chronic disease. That is to do away with the stigma of using the word obesity. So obesity is definitely a complex and multifactorial disease, and now the brain is at the center of it all. And as Dr. earlier said, that we have something called stomach hunger and something called brain hunger. Even when you're not hungry, you want to go and eat. And it happens often. If you're awake late at night, if you're doing some work, you just look for something to eat. And it usually could be calorie rich. So this was also spoken of by Dr. Tiwari earlier in the day, and when he spoke on the new ways of measuring obesity now, as height and divided by 2 is what should be. So I did my own calculation and I'm about 8 centimeters off the mark. So yes, that is a good calculation to use, and more than 135 million Indians are now affected by obesity, and approximately there will be at least doubling of that figure by 2040. So this is the ICMR INDIAB study that was referred to earlier, and this is data that is showing generalized obesity. So you can see here that the parts that are not covered are not because there's no obesity there, it's because the study has not been conducted there yet. So this is generalized obesity. On the right side is the urban obesity, and you can see that's more than 25%, and similar figures in the rural areas. But what you're going to see is alarming in the next slide. This is abdominal obesity, and that is a waist circumference of more than 90 for men and more than 80 centimeters for women. And you look at the slide down where you see the increasing numbers in the rural areas. And this was a prevalence of obesity study done in women, and you can see on the right, extreme right, what was the percentage of women, almost 45 to 50% of women having abdominal obesity. The factors that lead to gender disparities in obesity, and this could be because of disparate socioeconomic status, dissimilar literacy rates, mismatched sociocultural factors, but I think this is one of the most important factors, is feeding practices not only during pregnancy but also postpartum, when women are loaded with high calorie dense foods so that they are able to nourish the baby. Unfortunately, that's the time they gain maximum weight and are unable to lose. Contrasting biological craving of food is there, probably because of hormonal issues and divergent customs. And women eat food when they are happy, they eat food when they are sad, they eat food anytime. And it does. And if it is more like chaat and chole, it's any time is good time for eating food. So this is the life cycle in obesity. We know we feed children well, particularly where I come from in Bengal. The girl child is like a Durga, so she is fed very well, and then she ends up with polycystic ovarian disease, then diabetes during pregnancy, which is gestational, and then the progresses into obesity and other cardiometabolic disorders. So here prevalence of obesity in Indian women is almost 24%. And in India, more than 135 million people are affected by obesity, and this is expected to triple by 2040. So this, most of us know, is Dr. Yagnik's paper where transmission of obesity, adiposity of the mother, the pregnant mother, the overnutrition, ends up in either gestational diabetes and results in macrosomia for the infant. So our environment has definitely changed to promote obesogenic behaviors. We have high calorie dense foods, we have apps that we can order food at any time of the night. And there were times that I looked at to see, and there are still some restaurants that can give you food at 2 o'clock, at 3 o'clock in the night. So it's possible. Reducing our physical movement. So this slide tells it all, that we have got cars, we have got elevators, we have got lifts, we have large size of food, and we have also got a very sedentary lifestyle. In addition to that, as Dr. Tiwari already said, that we are using a lot of plastics. So there are a lot of obesogenic, endocrine disrupting chemicals. And where do they come from? In the bottles that we use, there's parabens, there's phthalates, there's biphenyls, and the sources of obesogens are many. And they are in our everyday life. So determinants of body weight are genes and environment, behavior, and biological factors. The root cause of obesity is what we need to address. Is it due to increased food habits? Is it due to availability of more calorie-rich foods? Is it mental health issues? Is it emotional issues? Women, particularly on emotional level, they are consuming a lot of calories. Whether it's non-timely eating patterns, whether it's frequent skipping of meals. And after COVID, it was observed that people are sleeping 2 hours later than they were usually. And as you keep awake more, you have this brain hunger where you just want to eat something, and it's not necessarily because your stomach needs something. So 5-step approach to managing long-term obesity is to ask the patient whether they are willing to undergo certain lifestyle changes to address the issue, to assess, as already said, by different anthropometric measures, by checking their thyroid levels, their lipid levels, whether to advise them, and how would you advise them? Just modest weight loss. Just look at 5%. I even look at 3%. And that's when patients tell me, oh, 3 is easy, I'll do it. I said, yeah, you'll do it. But you have to also maintain it. That is important. And so that is the feature we are going to look at next. We also need to agree that, okay, you will lose 3% and you will maintain it for 3 months and then you will go for the next weight loss. Sometimes it's very difficult. And we need to assist them in different things that they do. We are challenged by the industry that works on weight loss. They give you absurd weight loss challenges, and that is not healthy for our patients. So we use this Edmonton obesity staging system because obesity is now a disease. It has been classified by the International Classification of Disease as E66, and you can look it up, and it's non-billable. So you don't have insurance covering treatment for obesity. This is one of the Edmonton staging system you can look at. These are the 4M assessment of obesity. So it's not just mental. A lot of it is mental, particularly in women, where they undergo depression, attention deficit, addictions. And also we talk of addiction to food because of the surge of dopamine, but I think that's overplayed in some of the social media. It does play a role because there are certain foods that have got high level of addictive substances, mechanical, where there's sleep apnea, osteoarthritis. Many patients don't want to walk because they've got pain. They've got discomfort, they've got breathlessness. How do we attend to all this? And finally, they have metabolic disorders that we know about. But the monetary part is the most important, because when we put them through certain diets, we give them different foods. Sometimes we put them on powders for quick weight loss. So these could be some of the issues. So looking at this was the first diet doctor, George Shane, an Irish doctor who himself weighed 204 kilos. And so he put himself through a diet in 1732, and his dictum was no meat, so more of veg and fruits, little alcohol. I don't know what he meant by little because it's not there anywhere in the net, and good fresh air and some exercise. So with that, he was running a good weight loss program for his patients. We have many fad diets, and fad diets are defined as those that have not have a standard obesity recommendations, and they are often unreasonable in terms of weight loss and in terms of essential elements in your diet. So the high protein, low carb diet is the Atkins, and the Dukan and the South Beach, which are very, very famous. The moderate fat and low carb diet, which is the Nutri-System and Weight Watchers, and the low fat, very high carb, which is the Ornish diet, and the very low calorie diet, or the Slim Fast. Now, very low calorie diets are as much as 1,000 kilocalories, for women 1,200, and for men about 1,600 calories. And we know that when we calculate calories needed, so it's about 5 to 9 kilocalories per kg body weight to run your basic systems in the body. But we need a little more than that. So we give some calories that are 16 calories per kg body weight or even lower, so that we are giving our patients enough carbs and calories. A VLCD diet, helps patients to lose as much as 15 kg or greater, but then again, maintaining it is difficult. This is how we calculate, almost all of you know. Every single day we reduce 500 calories from your diet. At the end of 1 week, you would lose half a kg, and that's why we say 2 to 3 kg at the end of 3 months is a good way to lose weight. These are the health consequences of fad diets. So there's water imbalance, there's depression, there's appetite suppression, there's osteoporosis, inadequate intake of vitamins and minerals and certain deficiencies, lethargy, dehydration, exhaustion, and people are just not able to take those strict diets. So 48 randomized clinical trials with the largest weight loss were associated with low carb and low fat. And at the end of 6 months, there was a greater 1 kg loss in the low carb versus the low fat, but at the end of 12 months, both were same. So there was weight loss difference between individual diets, and it was minimal. So we need to remember that when studies done like this tell us that it's not healthy to lose too much weight, and to lose it with a balanced diet. These are various healthy diets that are also available: the Mediterranean diet, the mixed balanced diet, the Paleolithic, and these are healthy without omitting any foods from your diet. So looking at circadian rhythms now, circadian rhythms are run by two cues. One is for sleep, that is light, these are the Zeitbergers, and the second one is the hunger. So when we feel hungry, why we feel hungry, and these things have to be incorporated. We need to have best practices for developing a good circadian rhythm. And how can we do that? develop a regular sleep-wake cycle, sleep at the same time, even if it's a weekend, change your consumption habits, and how do you maintain these circadian rhythms? So you track your eating habits, you see what time you eat your breakfast, make it a protein-rich, good breakfast, and that's what we say. We must be eating a good protein at our breakfast in the morning. What are the symptoms of circadian rhythm? Often patients come and tell you difficulty in sleeping, difficulty in initiating, non-restorative sleep, exhaustion, poor concentration, and all these arise because we are not living within our circadian rhythms. So these are the 6 different types of intermittent fasting that is being recommended, and the most common one is the 16/8, wherein 16 hours you fast and you eat during the day for 8 hours. And you can eat generally everything as long as it's not, and anyway in those 8 hours you can't eat too much oily food or too much concentration of carbs. You have another diet which is easier, which is 5/2, so you fast on 2 days of the 7-day week. You eat, stop, eat, which is fast for 24 hours once or twice per week. Alternate day fasting, warrior dieting, which is really unhealthy. You fast during the day and have a huge meal at night. This is what is happening during the current fasting season of Ramzan. However, patients do lose weight during this time also. There is spontaneous meal skipping. So whenever you feel like missing a meal, you do it. That's also a kind of fast. However, this came under a lot of flack during the, in March itself, it came out on 26 that the 8-hour time restricted eating is linked to 91% higher risk of cardiovascular death. However, these were the counters given by those who go in depth into these studies, and this is from Dr. A.K. Singh in one of the groups at CME, that there were only 31 CV events in a total of 414 individuals in the less than 8-hour eating group over a median of 8 years. And this group only represented 2% of the people who were almost 20,000 patients. Of these, 60% were smokers. And that itself is a risk factor for cardiovascular disease. And 300% more black Americans were there in this group. And the assessment of the less than 8-hour duration was only on 2 days of the dietary recall. So this is not for us. In fact, our people have been doing an 8-hour eating, 16-hour fast for years. The Jains, the Jain communities, the people in Gujarat, people across rural India do that because of sometimes. Now, of course, our villages have become towns, so they don't have that problem, but in the past it was there. So time-restricted eating is never about counting calories. It's about being disciplined. If you remember, when we were small, parents insisted, dinner was served, you have to come. Leave your homework, leave your games, leave everything, or you won't get dinner after that. So that was healthy, right? We have a lot to see with the first morsel of food. Now, because lunch is ready and we are going to go for lunch, we are already thinking of what we are going to eat, what we are going to choose, we are salivating, and that is the appetitive phase. Then comes the consummatory phase, when we like what we eat, when we are going to enjoy what we are going to eat, and finally the satiety. Okay, now I know it's enough for me. So there's a lot of complex things going on in our brain as we look for food. What is the effect of sleep? Now that we are sleeping less and less, the effect of sleep is the short sleep duration causes changes in leptin and ghrelin. There is hedonic feeding. So you eat for pleasure. And because you are awake for, okay, so I'll just, so what are the challenges of, give me 2 minutes, okay? And finish it. So there are 2 things. One is prevention of weight gain, which differs from weight loss. So I've gained weight and I want to lose weight. But prevention of regain is when I have lost weight and I do not want to regain. So there are 2 different things. When we look at weight reduction, we have a finite period. So in 4 to 6 months I'll do, there's a wedding coming up, I'll lose weight, there's something going to be happening. And that is negative energy balance. You take in less than you burn. The prevention of weight gain, regain is far more difficult. And it takes place over a long period of time, and a bigger change is needed in your habits so that high levels of activity may be required. So while we were talking of carbs, calories, and circadian rhythms, long-term weight loss takes in physical activity, which is, there are 2-3 talks I think after this. So recommendations of physical activity is not only to improve your cardiometabolic state, but it gives you a lot of other endorphins release and the pleasure of losing weight. So maintaining weight loss is challenging. This was some studies done that showed good bit of 30 kg, up to 30 kg of weight loss. But what happens after 4 to 7 years? You're unable to keep up that loss, and it is about 5 kg of weight loss in most of them. So why do we find difficulty? Because weight maintenance is difficult. Easy, very easy to lose, say 5 kilos, 10 kilos, but maintaining that 5 kilos becomes difficult, and it's not your fault. Because there's a reduction in leptin, there's a reduction in your energy expenditure. And so you feel more hunger, and then you start conserving energy, and at the end of it, you lose weight. You gain weight at the end of it. So these are the lifestyle interventions for weight loss, and oh, the arrow is not showing. So the topmost one is only advice. You do this, you do that. You have a million people telling you how to lose weight. Then you have the second one, which is exercise alone. And you can see there's a dip at the end of 6 months, and again you don't lose weight. Then you have diet alone, which also works, but not as well as a very low calorie diet, which again is maintained only for 6 months, and then again. So this is the research behind using certain methods of weight loss, but we cannot sustain it for longer than 2 years. Brain and weight loss is now the subject of study, and the brain is now recognized as an insulin-sensitive organ. In fact, levels of insulin in the brain are more and several-fold higher than in blood plasma levels. And what does it do? It is present in the hypothalamus, the hippocampus, the amygdala, and the cerebral cortex. And these are all important sites for memory, for reward, for eating behavior, and regulation of the body metabolism. So this is what Doctor showed this slide earlier and focused on it. So the psychosocial burden of obesity, particularly in women, is high. There's depression, anxiety, quality of life, body image issues. A lot of people don't want to go for a walk. They don't want to get out and be seen by people. A lot of self-esteem issues, and resulting in a vicious circle of eating disorders. So I spoke about dopamine being one of the factors that could cause for highly processed foods, just as for gambling and games, and registers a pleasureful activity. So food addiction and the signs are compulsive eating, eating when you're not hungry, loss of control, negative consequences, and finally preoccupation with food. So what really works? We just need 5 to 10% of weight loss. We don't need more than that, and I will show you in the next slide. The relative risk to health and complications can be reduced by just losing 5%. Prevention of further weight gain or maintaining the weight may be more appropriate than actual weight loss. So these are the overall health improvements. You can see with just 0 to 5%, you reduce your blood pressure and you reduce your hyperglycemia. 5 to 10% weight loss helps you to prevent diabetes, the NAFLD or liver disorders, PCOD, and dyslipidemia with just 5 to 10%. When you lose 10 to 15%, you can see cardiovascular benefits, reflux disorders, obstructive sleep apnea syndromes, urinary stress and incontinence. A lot of women have issues with pregnancy, childbirth, and then they result in incontinence. And then with more than 15%, you can actually reverse diabetes, reverse cardiovascular mortality, and also reduce heart failure with preserved ejection fraction. We know that a lot of obese people have difficulty in walking. You can always ask them, how do they feel when they walk? This was a study for the cognitive behavior therapies for weight management. And this is the one that really works. This is the third wave cognitive behavior therapy. You can look it up. ACT or acceptance commitment therapy, DBT or dialectical behavior therapy, which involves emotional regulation. So don't blame yourself every time you feel like eating. Okay, this time I've eaten, the next time I will go less. And then there's mindfulness-based CBT. So these are the ones that really work. These are the details. And principles we know: portion control, get up early, eat, go for a walk, all that. So behavior modification could be just eating slowly, the way you less likely to be tempted. Do not eat fried snacks. Try using smaller plates. This really works. And importance of small but permanent changes. If you stop that one biscuit a day, at the end of 1 year, you could lose 2.5 kg. And similarly, if you walk just 1 kilometer, you burn enough to lose 2.5 kg in the year. So now you will be having many lectures coming on how to treat obesity. and that is by addressing the brain, by making you eat less and feeling sick when you look at your food. We are a food-loving nation. Our food changes from state to state. We cannot give up food. So we need to focus not on weight loss, but increase our physical activity and forget about the body weight. It gives us more health benefits. Consensus on the medical nutrition therapy says eat by the clock, no skipping of meals, ensure the recommended protein intake. We are really deficient. Across India, the starch study showed 60% of our food is starch and carbs. Oil intake per month for the house needs to be addressed. As much as 500 ml per person per day, and that's how much oil we should be using for a family. Knowledge of calorie intake and apps. So there are a lot of exercises, weightlifting, push-ups. We need to focus on muscle strengthening, bone strengthening, moderate exercise, vigorous exercise. Any exercise is good, any time of the day. We know that. Doctor has gone through this, so weight loss is not just about diet and exercise, it's a whole lot of other things that play on our mind. And this has also been endorsed by the American Association, ADA, and which focuses now on sitting and breaking up your sitting periods, stepping out, sleeping adequately where there is chronotherapy, and we look at physical and strengthening of the muscles. With that, I'm sorry I took a little time. And if you can find this on the net, this is one of the best exercises to do, just 3 minutes. There's no sound, but so you just keep doing that. It takes exactly 3 minutes, and if you just do it now, you could burn a few calories. I don't know if there is. So since the slides will be here, you can take this. There was music to this, it can't
It's
play?
okay.
So that I'll thank. If there's any question, I can take it on.
Thank you for the excellent session. Thank you, ma'am, for the excellent session.
Thank you.
Any questions from the audience? If we have time. Any question? No. So, thanks
you.
a lot. Thanks a lot.